consecutive video of exoscopic microsurgical management of complex anterior brainstem epidermoid with endoscope assistance. This 53-year gentleman presented with severe trigeminal neuralgia on the left side for 3 years, involving the whole face, upper, mid, and lower face. Examination showed glaucoma score 15, no deficits, left V1, V2, V3 hypoesthesia. With this, he was investigated with contrast MRI scan brain, showed an epidermoid anterior to the midbrain, pons with moderate pressure, extending up to the medial temporal region superiorly and extending up to the anterior lateral cerebellopontine angle space with a significant pressure on the trigeminal nerve and extending down up to the lower part of the pons, involving 7th, 8th, 6th, 7th, 8th nerves complex, as shown in these axial, sagittal, and coronal images. With this, he was taken up for surgery, underwent left retromastoid suboccipital craniotomy, left lateral cerebello-brainstem superior space microsurgical approach through the exoscope. With the help of endoscope, the whole tumor was excised, the trigeminal nerve and all the nerves from 3 to 12, all the blood vessels from midbrain, pons, and upper medulla. We prefer to do retromastoid suboccipital craniotomy. The scalp flap is raised in a semilunar fashion and 3 burr holes are made and they are connected with the cutter and the bone is elevated and taken out. Next, we drill the lateral part of the suboccipital craniotomy till we see the sigmoid sinus laterally and exposed. Sometimes the mastoid air cells get exposed. We need to close these mastoid air cells. Superiorly, the craniotomy goes up to the transverse sinus. That's very mandatory to expose to have a comfortable, smooth, and safe excision of posterior fossa or lateral cerebello-brainstem space lesions. Once that is done, the dura is opened in a cruciate fashion and gently the cerebellum is retracted. Now the lateral cerebello-brainstem space is exposed. The next important step is to open the arachnoid of the space and expose. Unless we open the arachnoid, we cannot reach these areas and excise the lesions. Now you can see once the arachnoid is open, there is the blood supply coming from the posterior temporal region, which is coagulated, and directly the trigeminal nerve is seen there, elevated towards us, that is posteriorly, and anterior to that there is an epidermoid. Capsule is opened and in between the 7th, 8th complex inferiorly and trigeminal nerve superiorly, the space is about 1 centimeter. Through that space, we start the dissection and debulking of the tube epidermoid and taking it out from the anterior aspect of the trigeminal nerve. The aim here is to decompress, remove the epidermoid 360 degrees from the trigeminal nerve. The epidermoid contains cholesterol and keratin. They cause the chemical reaction and lead to the neuralgia and secondary to the mechanical pressure. We need to take out completely around the root entry zone and all along the length of the trigeminal nerve. The whole tumor needs to be excised to have a relief from the trigeminal pain. Now we are going deeper and deeper, and the epidermoid anterior to the trigeminal nerve at the root entry zone at the pons is removed completely and all along the neck. Now this tumor is going down anterior to the 7th and 8th nerve complex, that is extracted into the space and brought and removed. Here the manipulation and handling of the 7th, 8th nerve complexes should be minimal and within the arachnoidal plane. This is of utmost importance because both are very sensitive nerves, and if we handle them more, and inadvertently we may cause the deficits in the form of hearing impairment and the severe vertigo or the giddiness patient may have postoperatively. Now the epidermoid anterior to the pons and anterior to the lower pons, anterior to the 7th-8th complex is being dissected and being brought out and taken out completely. That is the deeper part of the epidermoid. We are going deeper and deeper anterior to the pons, upper pons, and removing the lesion. Here, the tumor extends into the crevices and the deeper spaces where the microscope or exoscope may not show us the complete the extension of these lesions. So in these cases, we always prefer to use the endoscope at every stage to excise these lesions. Now, once we debulked and took off the inferior part at the level of 5th trigeminal, 5th nerve and the 7th, 8th complexes, now we are going superior to the trigeminal nerve, just below the tentorium, on the side of the midbrain and anterior to midbrain. Arachnoid is open, subtentorial region, and the epidermoid inside the arachnoidal plane is started debulking. At this juncture here, we need to keep a watch on 4th nerve and 3rd nerve, which travels at this juncture. Either they could be engulfed or encased by the epidermoid, or they may be shifted. We need to always keep looking for these cranial nerves to prevent postoperative visual deficits. Now you can see that in the space, the lesion is taken out completely. Now, due to the microscopic visualization restrictions, endoscope is of great help in this. We bring in the endoscope and see the remnant epidermoid and its location in relation to the surgical site, and locate that, and again either we can take it out microsurgically or we can use the endoscope and take it out along with the endoscope help. If it is coming out easily and comfortably with the microscope help, we can take it out. Now the lesion around the 3rd nerve, posterior communicating artery and posterior cerebral artery is being removed with the help of microscope and taken out. This is the superior part of the tumor, anterior and superior to the trigeminal nerve. Now you can see the posterior communicating artery and posterior cerebral artery. Still there is a tumor anterior to the midbrain at the level of the clivus or posterior clinoids, which is adherent to the bone, that needs to be taken out. Now with the endoscope help, that is dissected and gently separated. The movements here need to be very, very slow and gentle, because if we damage any vein or artery during the dissection, there may be bleeding beyond your vision and that may create a problem. Now with endoscope assistance, with the slow dissection, suction and blunt dissection, the lesion is being separated from the anterior part of the midbrain, superior part of the pons, and anterior midbrain around the 3rd and 4th cranial nerves and the basilar artery. That is the posterior cerebral artery, posterior communicating artery, and anterior part of the midbrain at the level of the posterior clinoids, which is going superiorly and medially into the temporal region. That is taken out completely now. You can see the superior part slowly, the bulk of the tumor is coming down significantly. Again, now we locate the lesion there and gently that is dissected. This is the medial temporal, which is going above the tentorium and medial part of the temporal lobe. We can excise it. We don't have to do the temporal craniotomy to access this part. At every stage, we keep washing the area with the piperine saline to prevent the vasospasm due to the tumor, chemical and the surgical handling is of utmost importance. Now you can see the trigeminal nerve is completely 360 degrees cleared and the superior most part of the tumor is still there around the 3rd nerve and 4th nerve. anterior to the midbrain at the level of posterior clinoids is gently separated and brought down superior to the trigeminal nerve. This is dissected and brought down into the space, lower space, and we can excise it, or you can extract it or remove it in the lower space. Slow, meticulous, gentle dissection is of utmost importance rather than hurrying up to take out this lesion. Now you can see that lesion, superior part of the tumor, is separated and brought down with the endoscope assistance dissection. Now that part also is removed. Now you can see the one which was separated by endoscope brings down, and through the microscope it is taken out. Endoscope, microscope in tandem is of utmost importance in dissecting these cases. Posterior and anterior part of the lesion is removed. Here the aim is to have safe maximum resection and decompress all the cranial nerves, that is trigeminal, faciovestibulocochlear and lower cranial nerves, and third nerve, and the vessels in the lateral cerebello-brainstem space, and keep washing the area with the pepperine saline to prevent vasospasm and take off the chemical material which is secreted by the tumor. The lesion is taken out completely. Now you can see the cranial nerves from top, 5th cranial nerve, 6th cranial nerve, 7th, 8th, and 9th, 10th, 11th cranial nerves are seen very well into the lateral cerebello-brainstem space. That's the basilar artery anteriorly. You can see the trochlear nerve there, the superiorly, and the basilar artery and the branches of the basilar artery and perforators going to the brainstem, that's midbrain, and pons are seen very well. This is the complete excision of the lesion anteriorly and decompressing or removing the tumor all around the trigeminal nerve, which he came for with the severe trigeminal pain. Now he will be completely relieved of that. Absolute hemostasis is achieved and confirmed. Dura mater is closed with the fascia muscle graft as much watertight as possible and scalp closed in 2 layers. This is a CT scan same day evening. You can see the tumor excised completely, no hemorrhage, edema, swelling, ventricles are normal, and medial temporal and anterior part of the brainstem and upper lateral medullary space lesion is excised completely. This is his post-operative clinical status on day 2. No neurological deficits, no cranial deficits, no motor deficits. He says his pain on the left side has gone completely and he's very happy. Whole space, that is ophthalmic, maxillary and mandibular division pain he had, very severe pain, has completely disappeared and he's quite happy. This is our neuroanesthesia team, treating physician, neuro rehab team. Our presence online with more than 630 microsurgical, exoscopic, endoscopic, navigation guided, educative neurosurgical operative procedural videos on our YouTube Neurosurgical Educative Video Atlas. Thank you very much for viewing.